mentioned, resources are dwindling, but we do have partnerships that are brewing, like this kind of partnership that we're having that has enabled this particular call. So Ismail, over to you so that you can give us a snippet of the objectives so that the delegates also understand what to expect today. Dr. Ismail.
Yeah, thank you so much, Lizzie. Hope me confirm whether I'm audible because
Yes.
I'm kind of in
All
a
good
crowded
to go.
place. Yeah, perfect. Yes, so Dr. Ismail Munyam, I'm the team lead at the Malaria Youth Champions Uganda. We are a group of highly motivated youth and young professionals, leveraging on our collective talents, energies, knowledges to really contribute to ending malaria in our country and Africa at large. We are part of the big End Malaria Youth Initiative from the Africa Leaders Malaria Alliance, and we are supporting the Uganda National Malaria Control Program and partners in country with the various End Malaria interventions. My role today was to just really give the overall objective of what this particular webinar is about. So the main objective of this webinar tonight is to share findings and recommendations from the Malaria Matchbox tool assessment. So we aim to facilitate discussions on how these findings and recommendations have been used to improve availability, accessibility, acceptability, and quality of malaria and health services for all the populations, with a particular focus on those most at risk or the underserved by the current interventions. Probably by the end of the webinar, we expect that the malaria communities and the civil societies on call, we expect them to have a stronger understanding of the challenges faced by malaria programs across the region. But I think the reason why we're having the mixture of people from the Anglophone, the Francophone, the Lusophone, to bring all those experiences on board. So this understanding will help identify new approaches for adapting programming to meet the needs of the high risk and observed population. So allow me to thank you so much for really taking off time to be around, and we are looking forward to a fruitful engagement. Thank you so much, Lizzie. Merci.
Thank you. Merci beaucoup. We're going to do that the whole afternoon today. Now, ladies and gentlemen, as I mentioned, communities and CSOs, we like making things a little bit interesting. And for today, we're going to actually just use a Mentimeter also to understand who we have in the room and where you're from. So perfect. Of course, the first country would be Kenya, home ground. But ladies and gentlemen, if you're on your mobile, on your phone, just go to www.menti.com and use 63602968. We just want to know, so far we have 3 people from Kenya. Where are you from and where are you joining us from? Without further ado, because I'll let that carry on. I was hoping to actually see Tanzania. Switzerland is in the house. That is good. As I mentioned earlier on, ladies and gentlemen, this particular webinar is to dive into this tool, the Malaria Matchbox tool. What does it do? What was the intention behind it? If you're new with this concept like I am, I'm trying to also get to learn a lot about the impact of this tool so far. And also, if you have experience, we'd like to hear from you. And there is a part for Q&A and comments that we would hope you'd also chime in and let us know what your experience was. But before we carry on, just to see, we have Tanzania in the house. Yes, Kenya, Switzerland. We're going to get to the next interesting part where we're understanding the general overview of this particular tool. These are interventions, and you know very well, we're still struggling with malaria, even though discussions have moved to other bigger issues like climate change, pandemic preparedness. We as communities, we're still feeling the impact of malaria itself, the deaths, the calamities. And we know there's a lot of breakthrough. We have 2 vaccines that are being used, but what other interventions are there? And that's why we're having this particular call. Nigerians are in the house. Niger, thank you very much. So I'm going to call upon Alistair. I don't know whether Alistair, you're on.
I'm here, and hopefully you can see me.
I can see you and I can hear you. Are you going to share your screen, or do we share the screen for you?
I can share mine.
Okay, perfect. So I'm going to stop sharing, but ladies and gentlemen, please carry on. Let me know which country you're from so that we can get the discussions lively. Over to you, Alistair.
Excuse me, can you repeat the...
Sorry, Eric was trying to ask something. Sorry, Eric, we muted you halfway. Was there something that you need?
Sorry. Okay, fine. Then you need the password for the
I will.
for
I'm going to put it on the
Ma-
chat.
Ma-
I'm going to
please.
put it on the
Thank-
chat. You're welcome.
Thank you.
Over to you, Alistair.
Thank you so much. And can you just confirm that you can see my screen and hear me?
Good to go.
Great. So thank you so much to the organizers for having me here to speak today. It's really wonderful to be here. I'm scrolling through the participant list and I actually know many of you, but for those of you who don't know me, I'm Alistair Shaw. I'm from the Community Rights and Gender Department at the Global Fund Secretariat in Geneva. I wear two hats at the Global Fund, one as the Human Rights Advisor, and one also coordinating our work on equity, human rights, and gender in the context of malaria. And that's why I was invited to join today. I only have 4 slides, but before I go through them, I just really wanted to take a moment to recognize the incredible efforts that many of you, and all of you actually, have already made to adapt your programming and introduce equity, human rights, and gender-related interventions into your work. Malaria programs, by nature, are designed to reach those most at risk of infection or those most likely to suffer from the poorest health outcomes. And so I think malaria programs do a really great job already of responding to inequities and human rights and gender barriers. But there's always more that we can do, and it's a partnership-wide approach. But I really do want to encourage you to continue making very purposeful and very ambitious steps toward removing barriers to malaria services. So let me start with why we need to focus on equity, human rights, and gender in our approach to malaria control and malaria elimination. We know, and for a long time, malaria programs have had a broad set of quality tools and quality approaches to fight malaria. We have ITNs, we have IRS, we have 2 new vaccines, we have chemoprevention, including SMC and IPT, and of course we have ACTs for case management. But our fight to end the epidemic has not really resulted in a significant enough decrease in incidence or mortality. So there's something we're not getting quite right. And that's why we need to really make sure that all of these really great interventions that we have, all of these really impactful biomedical interventions are being used effectively. So we know from a very significant amount of evidence that populations that are most vulnerable to malaria are the same people that have limited access to healthcare and all of these really important tools. And it's because of many different factors, including socio and cultural factors, economic factors, political factors, and geographies. The other thing we know from all of the evidence is that malaria can also exacerbate inequality and make people more likely to suffer the catastrophic consequences of poor health. So without considering all of these important factors as part of our response, we're unlikely to see a significant decrease in incidence and mortality, and we're unlikely to be able to really curb the epidemic to the point that we have been planning to do. So our team at the Global Fund, and in collaboration with our partners, with RBM, who I can see on the call, with national programs, but of course with civil society and communities, we collectively came together and we brought case studies into one technical brief, which you can see here on the right-hand side of the screen. And this technical brief describes some actions that can be taken to better understand barriers to healthcare and what can be done to create a much more enabling environment for service delivery, particularly in the context of malaria. So we have 5 areas from the Community Rights and Gender Department that we see as being critical to this response, which kind of brings me to the Malaria Matchbox. So really, we have these 5 recommended response areas on this slide. But as a starting point, we actually need to understand the malaria epidemic in detail. And that really goes beyond understanding transmission. And that's why we have the Malaria Matchbox and many other tools. The Malaria Matchbox is one of a few different known qualitative assessment tools that we can use to understand the different barriers that populations affected by malaria face in accessing healthcare, and really also helping us understand their experience when they're accessing healthcare. It kind of has two objectives. One is that it seeks to clarify for us as malaria program practitioners who and where the populations are that are most at risk or most underserved by existing interventions. And then it goes on for these populations to understand and look in detail at the factors that influence their access and engagement. So it looks at sociocultural factors, behaviors, intra-household inequities, so within the household, the inequities and inequalities that exist, accessibility, health literacy and digital literacy, economic capacity, and of course, geographies and understanding the way that villages and communities are structured and how that influences healthcare seeking. So all of these factors are critical in understanding how to design and develop and implement an effective malaria program. The Malaria Matchbox tool, which I have included a link here for on this slide, which you'll have access to, is available in English, in French, and in Portuguese. And it includes a step-by-step approach for how to conduct the assessment. And for the most part, these assessments are conducted by national malaria programs and supported by technical consultants. But of course, there is an expectation that communities and civil society, private partners, technical partners, and other partners in country are engaged throughout the process. So I've included at the very bottom of the slide here, just counting 6 key steps for the Malaria Matchbox assessment. And it is described in detail within the report. But it starts with inclusive methodology development, which means bringing together stakeholders from across the country to define the scope of the study, to really decide what it is that we want to focus on. We then have a desk review, looking at the current strategy and current interventions for the malaria program and understanding their current reach and the way that they're being implemented, and looking at other available evidence, including epidemiological data. We then move into a primary data collection period, which is generally around 2 weeks to 4 weeks in country, where consultants and a team managing the assessment are conducting interviews, focus groups with community members and those accessing malaria services, and also observing the way that malaria services are implemented. Once all of this information is collected and analyzed by the team, it then goes into a participatory validation process, which brings together different stakeholders again, as it could be the same stakeholders as during the methodology or a new group, including those that were interviewed, to discuss the findings and make sure that the findings really reflect what was heard by the research team, and to collectively come up with recommendations that make sense for the country and for the context. Once the recommendations are agreed upon, there's then a process to develop a costed action plan, which is where these recommendations are described in detail, including who should take responsibility of implementing those recommendations and the timeline in which they should be implemented, as well in some cases as the different funding modalities that are available to ensure that these recommendations can be taken forward. And finally, which I think is really why we're all here today, is then taking that action plan forward. What is it that we need to redesign? What is it that we need to adapt? And how can we actually move forward with implementing these really important recommendations to make sure that all populations have access to services? So on this slide, I just wanted to very briefly summarize where Matchbox assessments have already taken place. So in yellow and green are where those assessments have happened, either as a country assessment or as a regional assessment. And I've also given a bit of an indication of where assessments are currently in progress or where we're in the very early stages of thinking through how these assessments can move forward. So I'm really, really happy to say that we have over 30 countries, or by the end of the year, 30 countries that we expect to have completed this assessment, which is a huge increase from where we were just 1 or 2 years ago. And actually, if you look at this slide, most high burden countries have conducted an assessment. And actually, most countries in sub-Saharan Africa have conducted an assessment. So we have a lot of available evidence to use, which even if it's not your country assessment, I think there's still some relevant information that we can make sure is considered at a regional level as well. So finally, this is my final slide, thinking about next steps. While we have seen around 30 countries conducting assessments, we know that there are still gaps in programming because we haven't curbed the epidemic. It means that there's something that we haven't quite hit yet. So programming is really not then being consistently delivered and designed for all high-risk populations, and it means that some are still underserved. We were really happy at the Global Fund to have seen that as part of the funding request that came in, 2/3 of countries had actually conducted an assessment, whether it was the Matchbox assessment or another form of equity assessment. And that is a huge success for all of the countries that you're coming from and all of the national programs that are on the call today. The problem is, what we've seen is that actually out of those 2/3 of countries, only half of them were actually used to inform the funding request that came to the Global Fund. So of course, in country, those recommendations may have been used in other forms, in other ways. But in terms of Global Fund funding requests, we only saw around half of those assessments being used to inform the budgets and the design of activities that are receiving funding from the Global Fund. So it's really important that these assessments are not done just to tick a box, that we're really making use of the findings that come out of these assessments, and that we're using them to ensure that all populations have access to services, and that we can collectively end the epidemic together. So I'm going to leave it there with this kind of encouragement for the rest of this call, and I really look forward to hearing from the countries that will be presenting and hearing the discussions about how we can take this forward either at a country level or at a regional level. So thank you again, and I'll be here in the chat if you have any questions.
Perfect. Thank you, Alistair. Yes, please don't log off. I already have a lot of questions, but you know what? It's also good just to, the fact that you've started breaking it down into a language that I actually comprehend and I understand a little bit of the Matchbox, and I'm hoping that knowledge will grow by the end of the webinar itself. But I hear you and I concur. There's something we are not quite getting right. And we're hoping that through this call and through all these interventions, we will try and figure out and just pinpoint what that is. Ladies and gentlemen, welcome to the Malaria Matchbox webinar that we're having today. I need to apologize. Unfortunately, the call is only being translated from English to French and vice versa. I've seen a comment about Portuguese. My apologies. We've taken that into consideration. I know when you're getting into the call, you're automatically unmuted. So we'd request for you to mute yourself. Alternatively, we'll do the back and forth of muting you. But we've just gotten feedback from Alistair from the Global Fund, and I know we've also been posting and sharing the survey that's ongoing on the Global Fund processes. So we'll also put that link on the chat. I know deadline is on the 16th of June. So we'll also share that so that we can get feedback. Now, those kind of feedback also help the Global Fund understand the needs and the gaps that needs to be looked into. We're getting into the interesting bit where now we have people who actually have had experience with this particular intervention to give us their input. And thank you very much for staying on the call. We have over 100 participants. This is good. We're going to break it down into different countries who are going to speak about their own experience and what it looks like or what that has looked like over the years with the tool itself, particular intervention. So I'm going to call to the Kenyan team. And I know we have Patrick and Edward on the call. I'm not too sure who's going to start first, but Patrick, I did see you just to make sure that you're here. Please unmute. You're going to let us go through the presentation on the findings and recommendation that you have. Patrick, are you on the call? Or Edward?
Yes, Lizzie, and thank you so much. I hope you can hear me.
I can hear you. And before I hand it over to you so that you can introduce yourself and also give us a bit of information, we are community. As I mentioned, it's usually very interesting the way we do things. So we're using the Mentimeter, and I've seen a lot of people already there. Have you interacted with the Malaria Matchbox before? So just go to www.menti.com, use the code 63602968, the one you're seeing on the screen, and let us know if you've ever interacted. And we have feedback coming on. I know the French translator will also ensure to translate that to the team so that they can proceed and share that. So over to you, Patrick. Are you going to share your screen so that I can stop sharing mine?
Yes, please. I'll share my screen.
Perfect. Over to you. Please do
Okay,
introduce yourself and then take it away.
Thank you so much. I'm Patrick Igunza. I work for AMREF in Kenya on the Global Fund Malaria program. So I will be making a presentation together with a colleague that we are working closely with. He's on the call as well. He is Edward Mwangi. So we'll just give a brief experience on the malaria matchbox assessment that we did in Kenya in 2022. I'll make the introduction and I'll invite my colleague Edward to take us through the findings of the malaria matchbox assessment and how we have been able to use these findings in Kenya to inform programming and especially ensuring access to populations, the key vulnerable populations that have challenges or barriers to accessing malaria services within our country. So I'll give the introduction and then the assessment, the objectives and the methods that we used, while Edward will pick up from the background, the malaria matchbox assessments, all the way to the key activities that we have done post the malaria matchbox assessment. So yes, I think Alistair had gone through most of this, that the purpose of the malaria matchbox assessment is really to identify barriers to malaria prevention and care. And this could be broadly classified under social, cultural, financial, physical, and also barriers around the gender norms. So before we did the malaria matchbox assessment, we first of all did a mapping exercise just to identify those areas or communities that would have these barriers in the country. And from this mapping, we identified more than 22 at-risk populations, which included adolescents, pregnant teenagers, institutionalized children, at-risk populations like pastoralists and herders. We also had prisoners and pretrial detainees, as well as indigenous communities, ethnic communities, and stateless individuals. We also had registered and unregistered migrants, in refugee camps, and also within the urban centers. So this was the initial exercise that we did before we started on the matchbox assessment, because then this informed where we were going to do the assessment. So the impact really was to correlate the population data that we collected from the assessment so that this then could be used to improve the program effectiveness. And really the focus was on equity, ensuring inclusivity, and also right-based and gender-responsive healthcare services. And really the goal of this was to address the health inequalities and improve the malaria program outcomes across the various contexts and the populations. So these were the objectives of the assessment that we did. Broadly, it was to identify barriers to utilization of malaria interventions among the key and vulnerable disadvantaged populations in Kenya. And then we had the specific objectives to identify and map up specific areas in malaria endemic zones. In Kenya, we have around 5, the endemic zones are categorized in 5 regions. So as Edward will be talking through, he will give us what we found out from each of these regions. And then we're also to identify those key vulnerable populations, the ones that I'd already listed, that have that experience barriers to accessing malaria prevention, diagnosis, and treatment. Then we had to prioritize the human rights, cost, infrastructure, and social, cultural, and gender-related barriers to access to access and utilization of the malaria prevention, diagnosis, and treatment services among the key populations. I mean, what this means is that we were to find out which were the barriers of priority that if tackled, then they would improve the accessibility to malaria prevention and treatment services. So these three specific objectives led us to the three questions as highlighted. What are the barriers to accessing malaria services in Kenya? Which key vulnerable populations experience these barriers, and also the priority barriers that then we could tackle that were affecting these disadvantaged populations. So just from the guide that Alistair shared, we took a qualitative approach, and we did this in those 5 zones that I had mentioned. We have the lake endemic zone, the highland epidemic prone zone, we have the low risk zone, the coastal endemic zone, and then we have the elimination region. So those are the 5 key malaria epidemiological zones in Kenya. So we did interviews, we did key informant interviews, as well as had focus group discussions with the participants that were coming from those regions, the key vulnerable populations from those regions, and the data was analyzed using the Atlas TI 8 applications. Then we just presented this data by factoring in the themes that emerged from the qualitative data that we had collected. And this is what I'm inviting my colleague Edward Mwangi to also just take us through the findings. So I'll be presenting, and Edward, perhaps you can just introduce yourself, and then you pick up from the findings. Thank you.
Good afternoon, and thank you, Patrick. Good afternoon, participants. Thank you so much. I'm going to share just a small background, an extension of what Alistair has shared. But basically, for us to understand what we are presenting in terms of the findings, I thought it would be wise to just look at what is Matchbox and also the background around the Matchbox assessment. Next. Am I audible?
Yes.
Thank you. So as Alistair has put it, it's a tool that it's another additional tool that we as malaria practitioners are coming up to help us look at the populations that or groups of people that we are leaving behind that are not covered through the general interventions that we are looking at, but also the key social rights and the gender-related barriers that they are encountering, and how National Malaria Program can address these barriers. So it helps us to relook at the interventions we are deploying in a different lens. So next. At this, basically, traditionally, we look at the biological risk factors. That's the people who are born within the endemic regions have repeated attacks, and they acquire, for example, immunity because of that repeated attacks. Also, we have the non-immune populations that probably are visiting the high-risk endemic regions. So they are potentially to have severe disease because they have no immunity against the disease. Next. Then we have high-risk population, and these are traditionally what we have factored. That's children under 5 and also pregnant women, and the non-immune migrants, mobile populations that are within the high-risk areas. Next. Then we have populations that are affected by socioeconomic and cultural risk factors, such as poverty, literacy, financial burden. It can also be physical barriers like distance to the nearest health facility, stock out commodity security within those communities. Also human rights, for example, the immigrants and the refugees, but also looking at the cultural norms, maybe which gender can access which services at what time. Social exclusion population, those who are seeking economic opportunities, and also people in complex emergency. The other factor that we look at is that there are underserved populations, and these are populations that are living far from areas where, for example, government services are not there, or they are incarnated like the prisoners, or undocumented workers that are within the urban centers, and women and children from poor settings. Next. So the principles of the Matchbox assessment are usually around 5. We are looking at the multi-stakeholder engagement. Everybody has to be on the table when you are doing the assessment. You have to have good gender responsive approach when you are conducting the assessment, so that you can hear all the perspective of the different genders that you are bringing on the table. Then you must have also a right-based approach. This is that everybody who should be speaking should be on the table, and who should be affected by the assessment need to be sitting where decisions are being made. And further to that is it's not a hearsay. You have to have evidence to demonstrate that the decision you are taking is out of evidence, and then you need to coin an action or take action that is relevant to the barrier that you have identified. And this should also be contextualized within the country, the communities that we are planning to do the intervention. Next. So basically, the process is a pre-assessment phase in 2 phases, and also the assessment phase. So the country context, you engage the stakeholders and also form the assessment team from the stakeholders, and also develop the research proposal, and then plan and budget for that. This will help you when you're executing the assessment, because you need all those resources available or availed to have a successful assessment. In the assessment phase, you do a lot of desk review. Then you are able to—
Sorry, Edward, maybe just to let you know that you have 2 more minutes, maybe.
Okay.
Thanks.
So, yeah, so the assessment phase is a 3-step. Next. So in Kenya, out of the 22 groups, we were able to come up with 9. I'm not going to read through. I'm hoping this will be shared. So these are the key vulnerable population definition. Patrick, next to the findings. So what we did is to base our finding on the strategies that were there in the Kenya malaria strategy that was existing then, and we were able to propose the actions that were required per strategy. For example, in vector control, we were looking at the IRS strategy, especially populations that are not benefiting from that strategy. Number 2 is on mass distribution to cover KVP. This is just to increase, for example, PWDs who are not targeted or covered. Ideally, we plan to cover everybody, but we need to put extra effort for some of these groups. Next. Patrick, next slide. So for case management, this is how the objective read, but also the proposed policy decision were basically to facilitate community case management, especially to the KVP, key vulnerable population, where the barriers had been identified. Also, capacity building of private sector providers, and also reviewing and enhancing the training curriculum. Next. Number 3 was on elimination counties, and this basically was to engage in passive adaptive surveillance systems to detect malaria cases, especially among KVPs, This is to encourage early detection and management of malaria, and also SBC. For SBC also, we were looking at a targeted SBC program that is culturally, language, and format appropriate, but also task shifting policy communicated to help in targeting key vulnerable population. Rollout of human rights health literacy program and capacity building of health workforce on community, on CLG issues in the health delivery. Next. For data for decision making, surveillance, we were talking about conducting surveillance in institutions like running institutions, barracks, camps, prisons, etc. But also carrying out the assessment to inform equity in the design and implementation of the program. And lastly is to engage in community engagement, human rights, and also gender mainstreaming in the indicators and the definition of the indicators for malaria program. Lastly, next slide. Next slide. This is on how often we should be able to conduct the Matchbox, but also strengthening partnerships with agencies that is working with KVP to design appropriate malaria intervention. Next. Also alternative malaria commodity supply chain for KVP, especially in the informal and urban population, but also developing innovative digital approaches for malaria. So these are the actions that were done in two phases, the short term and also the long term. So mapping of KVP, which have already been done, the initial mapping was done, but also designing a promotion of malaria health literacy. That has not been done yet, but is planned for the coming GC7 implementation. Know Your Right program also is ongoing in the GC7. And private sector engagement in the delivery of quality assured malaria intervention as part of the national malaria guideline. That is in the works because we are in the process of developing the national malaria strategy. And it's one of the areas that we are looking to influencing to have it done. Then we also looking at rollout of risk communication. That has been partially done in the last COVID grant. But in the next 2 to 5 years, we are looking at guidance, for example, for rollout of community case management and guidelines that include the inclusion of KVP in different interventions that are carried and working in partnership with other programs. Next. Key activities that have been done. We've done partial dissemination of the Matchbox and also participation of the of CSO in malaria program review, Kenya Malaria Strategy, and Malaria National Policy Development, which is an ongoing activity that we are participating on. We also supported the GC7 in grant making. We are hoping to start implementation in July. And lastly, support in the SBC campaigns that is also ongoing. The last slide is, thank you.
Yes, it's the smiley one that I always look forward to. Now, this is the advantage of always being the first presenter. When you're given 5 minutes, you can run for 15. But ladies and gentlemen, that was very much appreciated from the AMREF team. We thank you very much for that. And yes, I've seen the questions coming in. We will share these presentations after the call and also the link to this particular recording. We're going to move to Malawi team. And because we've got 2 presentations from the Global Fund and AMREF, just letting us know what the malaria Matchbox tool is, what it is and what it entails and how it works. We're going to go to Malawi. Sosten, you're going to take us directly to your recommendations and findings, because now we already have a rough idea of what the tool does. Is Sosten there? If the AMREF team can stop sharing the screen, that would be amazing. Thank you. Sosten from Malawi. Sosten, are you there?
Yes, I'm here.
Perfect. Are you sharing your screen?
No, you can share it for me.
Okay. Inasa team, I'm assuming you already have Sosten's presentation. Thank you, Glory. If we can just go, Sosten, which slides is talking about the recommendations and findings? So that we can just, maybe in the meantime, you can introduce yourself and then you have,
Can you?
yes, I can hear you and we can see your presentation.
Yeah, I'm Sosten Lankrani,
Yes,
working
and you
with the
have
National
you have
Malaria Control Program
5 to 7 minutes, Sosten, just to
here in
push.
Malawi.
Thank you.
Oh, then let's go to the next slide. Yeah, let's just go to the findings, slide of findings. These I already know my colleagues touched on them. So let's go down. Yeah, let me start from here. I'll be closing at hypersonic speed. So let's go to recommendations. Yes. Yeah. So in our summary findings, our first you are moving too fast. These are the recommendations. So I will go into the vector control case management. Sorry, you are moving too much here and there.
Sorry about that. Which slide do you want? The recommendations or the findings?
Can you go to recommendations? The time is too minimal. Let's go to
Okay.
recommendations.
Recommendations, please, Richard. Thank you.
Yes. Next slide then. Next. Yeah, on the recommendations, we have divide them into the
Are you able
thematic
to
areas.
see?
Yes, we can see.
Yes,
Okay.
I can see. So we are starting with the vector control. On vector control, for this year, we are also having the mass distribution of nets. So during our findings, we found that there's no ownership, no net distribution in schools, orphanages, and also to prisons. So we recommended that in boarding schools, we have to start distributing nets, and also in orphanages. So in prison, the sleeping spaces are not cannot suffice distributing nets. So we propose to start IRS. So
Sosten, I think you've been muted. Sorry. I know you're speaking, but you're on mute.
so now, can you hear me now?
Yes, now loud and clear. Carry on.
Maybe somebody muted me. I said on vector control, we are now concentrating on boarding schools, which previously were not benefiting. They were just being distributed in households. So when the school children comes from school to their homes, they find that the nets which we distributed to their households, they are not there. We don't know where they have gone, but they are the children who are being missed. And also to prisons, the sleeping spaces are not conducive for nets. So we propose to start doing IRS, insecticide, indoor residual spraying. So we are starting this year. We did the indoor residual spraying last year in 4 districts. So some insecticides remain. So we are using those remaining insecticides to do the IRS in the regions. Next slide. Next slide. Yes. Next. Here. So we want to collaborate with Ministry of Education so that the schools should own the nets when we distribute them in schools. They have to take care of them when the children are going to into the holidays. the nets should remain as the property of the school. When they come from holiday to school, those students who access the nets, and also want to collaborate with the IMCI program so that the equity, human rights, and gender should trickle down to the community level as well. Next. Next slide. Yes, on SBCC, we want to uniformize or standardize the messages we are giving to our population. They have to be tailored to the needs of those populations. And also, we have to develop user-friendly tailored messages, and also in other specified populations, like those who can't see, the blind ones. Want to at least include them by coming up with the braille materials so that these populations can also benefit from these messages. And also we have to explain about the myths of the nets, and also have to this can lead to acceptability of the nets in households. And we want to strengthen community engagement to address the mitigation and social norms, perception, practices, and misconceptions. We want to use the people to be the people should be centered, so that every influencer in their communities should be engaged. They have to be ambassadors of the messages we are developing, so that our community can trust them. And we want to unpack the respected community values, gender, and social negatively impact malaria programs across the targeted. We have to allow individuals to discuss the negative social norms, and also co-create feasible and practical for malaria treatment uptake within their household communities. We have to understand in depth of the society dynamics, so that we have to build the positive alternatives norms, particularly around misconception on prevention and treatment of malaria. Next. Next slide. Next. Okay, on sensitization, we want to build on the okay, want to also to expand the youth-friendly services to optimize our use of mobile phones, so that the young people of now should benefit a lot, and they should act as ambassadors as well. And on the use of Chipata Chapa phone, this is called a clinic on the phone. We use a phone so that people should be calling, seeking for information, and there are health care providers to provide that. We want to also to use the already available partners working in the communities, so that they should also engage the communities on the same messages we are developing. And also want to engage the big companies who are operating in these communities, like the ones which are providing the internet, mobile services like TNM and Airtel, and also involve the sugar making companies like the Ilovo, which do interact with the people in their natural habitats in the communities. Next. So in case management, we are also expanding the case management beyond the hard to reach areas which they are provided by community health workers. We want to understand the populations which even can't be reached by this community services, so that we have to find another means of catching them. For example, we have a key population like albinos. These albinos do fear to go to the hospital, yet when they suffer in their communities, they do suffer without going to the hospital. So we are targeting those kind of people, and also they are chronic ill people which cannot be taken to the hospital, yet we can reach them using other means. Yes, also we are expanding the same ICCM through training of the community health workers, and also giving them really the enough package to be assisting people. We are also expanding innovative mechanism like the learners treatment kit. This is the system whereby we found that the prevalence of malaria is high in the school-going children. We always emphasize on the under 5, but now there's a shift of malaria from the under 5s to school-going children. So we are going to the schools, train teachers, and train them using also MRDD, malaria rapid diagnostic test. So when the child presents to them with a fever, they do test right there in the school, and if found positive, they treat them. So this also reduces absenteeism. Apart from that, we have improved access to malaria services. And also men and boys are left behind. Yeah. So because they are also the ones who also make the decisions to visit the health care providers. And then
is this
but
the
not
last
least, on
slide?
the program management, we want to there are I think 2 or 3 last ones, but
Oh yeah, you have less
almost
than a
similar.
minute. If you can just summarize that. Thank you.
Okay. Strengthen and efficient effective coordination and implementation of our strategy and their program activities, and NMC will also to widely disseminate the strategy to MDAs and also the, other partners. Next slide. Next as well. These are almost the same program management.
Okay.
Next. So on this, we are also working with the Ministry of Gender, because we have gender ministry which also look at the people with disabilities. So by coordinating with them, we'll be able to reach these key populations. Next. And that the M&E should develop and design gender responsive equity indicators, which are also measurable. Next. And we have also to, when refreshing people, we have to emphasize on the equity, human rights, and gender. So all in all, communities in the country are at risk of malaria, but others they are at very high risk due to the living conditions, social, cultural, and negative influence of harmful norms and attitudes and practices. Hence, addressing equity and inequality barriers to malaria will be important to achieve the zero malaria in Malawi. That's the last slide.
Thank you, Sosten. I appreciate it.
Thank
And I know
it
the
has been a
slides
marathon.
also.
Apologies, but
No, my apologies. I mean, this is a lot of crucial information. It's just that we also have to keep time. But as we mentioned, ladies and gentlemen, we're going to share the slides immediately after this call so that you can go through all the content that's there. Thank you, Sosten. We're taking it back to the Francophone speaking countries now. We just had from AMREF, Kenya. We've had from Malawi, from Sosten. Now we're going to Benin, where we have, I might butcher your name, Doc, but Dr. Afoko. Are you on the call?
Oui, je suis là.
Perfect. Thank you. Thank you, Doc. So I'm hoping you will also go directly to the findings and recommendations. You have 5 minutes for your presentation.
On a été victime de... C'est pas gentil. Bon, on peut afficher
Sorry
les
about
présentations.
that.
Oui, en attendant qu'on affiche, je tiens à dire que le Matchbox a été réalisé au Bénin. C'était une recommandation du TRP, du Fonds mondial. Et nous avons bénéficié de l'appui du Rollback Malaria pour le financement du consultant international et du Fonds mondial pour le recrutement d'un cabinet au niveau local. Et il y a une implication active du PNLP à travers une cellule équité genre droits humains que nous avons installée au niveau du programme. Le costing a été fait avec l'appui. Et donc voilà, en résumé. J'attends on affiche la présentation, s'il vous plaît.
Yes. Yes.
Ah. Donc je voudrais dire que cette présentation sera faite par le président de la cellule équité genre droits humains du PNLP, Monsieur Saliou Ramon.
Merci beaucoup.
Yes, if we
Merci.
can go directly to the recommendations.
OK. Ok. Bon, merci beaucoup. Je crois qu'en ce qui concerne les recommandations, et ces recommandations étaient classées en fonction des domaines d'intervention et de, oui, et des orientations du Fonds mondial. Et donc, premièrement, nous, comme recommandation, nous demandons de former tous les acteurs impliqués dans l'élaboration des documents stratégiques et la planification des interventions de lutte contre le paludisme sur l'intégration du genre et des droits humains, de prendre en compte les groupes de population mal desservis exposés au paludisme en dehors des femmes et des enfants de moins de 5 ans dans le processus de mesure des indicateurs désagrégés, et de stratifier les interventions en tenant compte des régions enclavées dont l'accès aux services de lutte contre le paludisme est entravé par des obstacles géographiques, sociaux, culturels, sécuritaires, catastrophiques et naturels, c'est-à-dire les inondations et les insécurités. Diapo. Slide. Slide. OK. Toujours dans ce domaine, il faut élaborer un document de référence spécifique sur le paludisme, le genre et les droits humains au Bénin, et d'assurer la diffusion du document de référence au profit de tous les acteurs de lutte contre le paludisme, tout en veillant à sa mise en application. Diapo. Slide. OK. Dans le domaine de prévention du paludisme, c'est de mettre en place un mécanisme de pérennisation des initiatives d'amélioration continue du cadre de vie, de l'hygiène et de l'assainissement par les communautés à la base dans tous les départements, et d'améliorer la stratégie de distribution des moustiquaires imprégnés d'insecticides à longue durée d'action pour plus d'équité, tout en précisant dans les directives nationales les mécanismes pour atteindre les groupes mal desservis et plus exposés au paludisme, et de développer des moyens de prévention adaptés à certains groupes particuliers, tels que les personnes privées de liberté qui ne peuvent utiliser les mildes. OK. De développer d'autres mesures de prévention qui permettront aux populations de se protéger contre les piqûres de moustiques lorsqu'elles sont hors de leur ménage. Diapo. Slide. OK. Dans le domaine de la chimioprévention du paludisme, nous recommandons de vacciner tous les enfants de 0 à 5 ans contre le paludisme et d'élargir la CPS aux enfants de 5 à 10 ans, de rendre fonctionnel le système communautaire en mettant les agents de santé communautaires et comme acteurs premiers de recours aux soins du paludisme et de veiller à la mise en œuvre de la chimioprévention pérenne aux enfants des personnes privées de liberté et du traitement préventif intermittent aux femmes enceintes privées de liberté. Slide. OK. En conclusion, nous disons que partant des résultats obtenus, il est impérieux qu'une synergie d'action entre le PNLP et les ministères de cadre de vie, des affaires sociales, des enseignements et de la communication, ainsi que les acteurs de la société civile, s'avère nécessaire pour ne laisser personne en rade dans la lutte contre le paludisme. Par ailleurs, la planification des interventions devrait tenir compte des spécificités des différents groupes de population et obstacles mis en exergue. Merci.
Très bien. Donc, voilà ce qui a été fait. Il faut reconnaître que à la suite de cette étude, il y a un plan budgétisé qui a été fait et d'abord qui a permis de définir les actions à mettre en œuvre. Une partie a été consacrée pour le dernier trimestre de 2023 et le reste des actions, c'est sur les 3 années à venir suivant la subvention du Fonds mondial. Je peux vous rassurer que pour le plan d'action pour le 3e trimestre 2023, ça a été entièrement exécuté. Donc voilà, en résumé, nous tenons à vous remercier pour le partage de cette expérience. C'est dommage qu'on n'a pas eu suffisamment de temps pour vous dire comment ça a été fait avec quelques spécificités relatives au Matchbox Bénin. Merci à vous.
And my apologies, Doc, for kind of rushing you through the slides. But just to connect the last 3 presentations we've seen when we're talking about gender and human rights, those are coming out super strongly. We've seen that we still have populations that are being left behind, like prisons. We've seen the youth, which I'm pretty sure Dr. Ismail is smiling, knowing that that has already been tackled. But we've also seen there's a need for stakeholders, relevant stakeholders. But what I like is that this particular toolbox is bringing up the strength of communities and the role that communities play during this particular interventions. So we started off with the Anglophone, we're still doing the Francophone bit, and we're going back to DRC Congo, and we have Clarice on the call who's going to take us through their findings and also their recommendations. You have 5 minutes, and I know we have your presentation. Clarice, are you on the call? Just to double check with the ENASO team if we have Clarice on the call still.
Yeah, I see Clarice. Ida, is this Clarice MBO the one?
Oui, c'est Clarisse, c'est bien moi. Mais
Perfect.
je vous frappe
Okay.
positivement.
Great. Nice meeting you, Clarice.
Oui.
So you have 5 minutes. I know we have your presentation, so we'll just share that.
Oui, okay. Est-ce que comme I don't speak English very well,
Please
mais
speak French. Yeah.
je vais présenter ça en français. Et la personne, comme j'ai 5 minutes, on peut aller directement aux recommandations. Et je voudrais dire que on peut passer à la présentation. Est-ce qu'on
It will be good you start with the findings, just briefly, then recommendations.
Liz, can they guide me because I can't read French? Can they guide me where I should start?
Oui, yes. We'll have the French translator also help with that.
L'activité Matchbox a été réalisée en RDC dans 12 provinces. Et on a réalisé ces activités. Nous sommes allés, le choix était sur 12 zones de santé. On a pris une zone de santé urbaine et une zone de santé rurale. Ça veut dire pour les 6 provinces, on a été dans 12 zones. J'aimerais que vous alliez directement aux recommandations puisque on m'a accordé 5 minutes. Si vous pouvez passer directement aux recommandations. Allô? J'aimerais que le présentateur passe directement aux recommandations. On a, pendant cette étude, nous avons fait des focus group aux différents groupes cibles. Et nos groupes cibles étaient composés de
Clarisse, we've lost you.
recommandations.
Oh, there she is.
Il y avait des recommandations liées aux problèmes liés à la barrière socio-culturelle et linguistique, où on avait demandé de recruter davantage et améliorer le statut des agents de santé communautaire, en particulier au sein de la population vulnérable, en renforçant leur capacité. Donc, j'ai vraiment un petit souci de connexion ici. Donc, ce que je disais là tantôt, il y avait plusieurs barrières. Il y avait la barrière socio-culturelle et linguistique. C'est qu'on avait demandé de recruter davantage et améliorer les statuts des agents de santé communautaire. Ce sont ceux-là qui font la sensibilisation au niveau de la communauté et au sein des groupes vulnérables. Et il fallait aussi veiller à ce que les interventions prennent en compte les attitudes et croyances problématiques en matière de prévention du paludisme, notamment en ce qui concerne les moustiquaires imprégnés, puisqu'il y a des comportements à problème, il y a ceux qui ne dorment pas sous la moustiquaire. Est-ce que vous m'entendez? Vous m'entendez?
Non, non, non.
Allô?
Faiblement, faiblement.
Vous m'entendez?
Yes, we can hear you.
Ouais. Il fallait aussi impliquer des pères éducateurs attachés à des groupes spécifiques tels que les populations autochtones, les pygmées, les pêcheurs, les travailleurs qui travaillent dans les mines, et ceux qui sont dans les montagnes, les prisonniers, les enfants qui vivent dans la rue, et c'était un peu ça. Il y avait aussi des obstacles physiques et environnementaux. Et là, on a demandé à ce qu'on renforce la mise en œuvre des interventions de prévention et le contrôle du paludisme dans la communauté vivant dans les zones d'accès difficile. Ici, en RDC, il y a des communautés qui vivent au-delà de 10 km, où la communauté fait plus de 5 heures de marche pour arriver dans le là où il y a des barrières, là où il y a la colline, des montagnes, où il y a des rivières. C'est ainsi qu'on a demandé qu'on renforce les interventions à ces endroits-là, d'accélérer la mise en œuvre de sites de soins communautaires dans toute l'étendue du territoire national. Donc, qui dit les sites de soins communautaires, c'est la CISNIEM. Il y avait la croyance et pratique traditionnelle au traitement du paludisme. Et là, on a demandé d'accentuer la sensibilisation des populations sur la nécessité de fréquenter les centres de santé, impliquer les vendeurs. Il y avait vraiment un accent d'impliquer les vendeurs et des médicaments locaux dans les activités liées à la prévention et au contrôle du paludisme. Vous m'attendez? Je peux continuer? Allô? On devait
Sorry
impliquer
about
les
that. We'll
vendeurs.
mute.
Est-ce que vous m'entendez? Vous m'écoutez? Allô?
Yes,
Allô?
we can hear you.
Ouais. J'étais d'abord j'ai suivi les croyances physiques et environnementaux. Je suis aux croyances et pratiques traditionnelles pour le traitement du paludisme. On a dit qu'on devait accentuer la sensibilisation des populations sur la nécessité de fréquenter les centres de santé. C'est aussi les vendeurs de médicaments locaux, des activités liées à la Allô?
Oh, okay. Clarisse, are you
Allô?
back? Can you hear us?
Oui, j'ai des difficultés de connexion.
Clarisse?
Je suis là, mais vous m'entendez?
Okay.
Bon, j'étais aux obstacles financiers. La question principale financière, c'était fournir les informations régulières sur les services gratuits de la lutte contre le paludisme, puisque la population ne savait pas que le traitement du paludisme, ainsi qu'on devait sensibiliser la communauté, les membres de communauté pour la gratuité. Sensibiliser la des comportements inappropriés visant à atténuer la gratuité de certains services de lutte contre le paludisme, puisqu'il y a des médicaments qui étaient destinés à la gratuité et dans certains centres, on vendait. Alors, on a demandé à ce que dans le Matchbox, que nous sensibilisons nos communautés, leur dire que le traitement du paludisme est gratuit. Le TDR est gratuit, le traitement est gratuit. Il y avait aussi une influence de normes de genre. Donc, intensifier les efforts pour intégrer les éléments de prévention de lutte contre le paludisme dans les activités visant à atteindre les femmes, les enfants dans la situation critique pour répondre à leurs besoins en matière de santé et de survie. Par exemple, les femmes qui vivent dans les cas de déplacés, ici nous avons eu des déplacés de guerre, nous avons eu des déplacés de Nirangongo, il y a des déplacés aussi comment dire, des conflits, et on a demandé qu'on intensifie la formation de ces femmes-là. Et il y a eu aussi relever les défis des niveaux d'implication des femmes dans les activités communautaires d'éducation et de promotion de la santé pour la prévention et le contrôle du paludisme et d'autres besoins sanitaires. Améliorer la disponibilité des données qualitatives et quantitatives des agrégés et faveur du paludisme du pays. Et la
Oh, okay.
Et pour conclure, et qu'est-ce qu'on a trouvé les activités visent à renforcer la sensibilisation des membres de communautés
No worries. I think
communication de masse ou interpersonnelle. La causerie éducative par le relais communautaire.
Thank you, Merci for that presentation. And thank you very much, Clarice. I know we've been having technical glitches, which is also one particular barrier to eradication of malaria, but thank you very much for holding in there. Richard, if you can stop sharing the screen. Ladies and gentlemen, we've got to the part where... Merci, Clarice, merci.
Merci, j'ai eu beaucoup de problèmes pour la connexion et je vous remercie quand même. En projetant, les gens ont pu...
Yes, the connection was quite a challenge, but what we've seen in overall all the four countries that have presented is we do know there are vulnerable populations that have been left behind, and we know the tool itself is helping to identify barriers to malaria prevention and cure. And what I like is, even if we didn't actually push some of the speakers to run to their recommendations and their findings, you'll notice that there is connection to whatever presentation from when we started with Global Fund all the way till the end, where we got Clarice giving us her conclusion. So we've got to the part where we're open for Q&A, and I've seen Malawi already taking some of the questions on the chat, but I'll just start with Benin. I'm hoping, Doc, you're still around. We have this toolbox, this intervention that has collected a lot of data that is actually a true representation of what is going on ground, especially in communities. And I like what Clarice was saying, qualitative and quantitative data is crucial when we're trying to, also identify these barriers and how to tackle these particular barriers. So I'm going to ask Dr. from Benin, I think you're still on the call. Just to clarify, did we lose him, Glory? But no worries, this is the same question that's going to go to all four presenters, especially I know how big Amref and other colleagues are in advocating for last mile. So what are we doing with this data that we've got? And how is it informing not only the advocacy efforts, but also the budgetary angle of the public sector? So I'll start with Patrick or Edward, if you're ready to take this particular question, and then we'll go to Sosten.
Yes, thank you, Lizzie. And I know Edward will also chip in. Yeah, but in terms of the data that has been collected, this is very valuable data. For Kenya, I think this was the very first malaria matchbox assessment that we did. And using this data, actually it has brought into the limelight the issues of inequitable distribution of or inequitable access to resources. And with that, then even at this point where we are developing the next Kenya malaria strategy, we have really based our strategies, especially around the human rights and gender, and also considering the key vulnerable population. We have really borrowed a lot from the findings, sort of from the report of the Kenya Malaria Matchbox assessment. So it's not data that is just going to lie in the books or in the reports, but this is data that has we have started using to inform decisions and also to inform programming. Thank you so much. Edward, if you want to add something.
Thank you, Patrick. I think at the policy level, we are using it to inform the policy development. But at the implementation, there are some of the work that has already begun, especially for the vulnerable population, and engaging them through the community engagement and also reaching out to new partners that we have we had not worked with before. So it's a very valuable information guide to inform the implementation, but also at the policy level. Thank you.
Yeah, thank you very much for bringing that aspect. And I know I was going to call out for Malawi, but I'm going back to Alistair. Now, Alistair, we have enough content which should be informing even the budgetary allocation, but we see the amount of budget going to malaria prevention and cure, it's actually dwindling despite all this data that we have. And I know you said there's something we're still not doing quite right. In your point of view, how helpful is this malaria toolbox data that's been collected in actually pushing for policies to increase budgetary allocation in the fight against malaria, and also how easy is it to use, or how accessible is it to use this particular toolbox? Because we were doing a Mentimeter behind the scene, and it looks like also a good number of people have not interacted with the toolbox itself. Alistair, over to you.
Thanks so much. Hopefully you can see me again.
Yes.
I think these are both excellent questions. Maybe I'll start with the second question first around the use of the Malaria Matchbox tool. And the comment in the chat, and as you've mentioned, really around community and civil society engagement with that tool. I think it's a really excellent point, and civil society and community engagement is critical to the Malaria Matchbox tool, but more broadly to the entire malaria response, from the design, the delivery, the evaluation of malaria services. If anyone has had a chance to look at the Malaria Matchbox tool in detail, that it breaks down the process of conducting the assessment. The tool was actually developed for national malaria programs. It wasn't developed for anyone to pick up and use. It was developed for national malaria control programs, but it was expected, and it is clearly articulated in the assessment document, that civil society and communities should be engaged in the process from start to finish. So I don't really see this as something that everyone on this call should take and go and implement within their communities. Of course, there are valuable annexes within that and tools that can be used as part of your work, but as a big toolkit, it's not something that everyone should take on. It is an incredibly complex assessment that needs engagement from many stakeholders. So if you haven't engaged in the assessment report, I would say that in the assessment process, I would say that that's a little bit disappointing, but it's not a missed opportunity yet, because it is important that you're engaged in the way that these recommendations are carried forward into implementation. So there's always still an opportunity to engage. On the second question around budget, I think that that's also a really important comment that was made. I would argue in some way that the Matchbox assessment findings are not put out for the purpose of increasing resources toward a specific area, but really to help us understand how to make the tools that are already available much more efficient and effective and impactful. So sometimes it's really only about adapting and changing the way that we deliver services and making sure that they are accessible to different populations. But of course, in others, it does require dedicated resourcing. So we have seen some increases in some countries where the findings have come forward into specific budget lines that have been funded by the Global Fund. And I hope that we'll continue to see requests for funding for these recommendations in future funding requests, but of course, also as part of grant revisions that happen throughout the grant cycle. So there are still many other opportunities to ensure that these findings are funded and actually taken forward by different partners within the country.
Yeah, perfect. Thank you, Alistair. I saw Sunny Saleh, your hand was up. But ladies and gentlemen, this is the part where if you've had any sort of interaction with the malaria toolbox, please feel free to raise your hand so that we can share experiences as communities. And I like what Alistair said. It's not something that we as communities will just pick up and start adapting, but this is on a national level, and it's something that, you know, I mean, if it was working very well, if the health system was working very well, one point or the other, we will interact with it, or we might have interacted with it. Sunny Saleh, if you can just unmute and ask your question. or comment? Sunny?
Oui,
Okay.
bonsoir. Vous
Bonsoir.
m'entendez? Oui, bonsoir, vous m'entendez? Ok.
Oui, we can
Donc,
hear.
j'ai déjà écrit un peu au niveau du chat là pour ajouter un peu le groupe cible. Donc, d'abord, il y a les enfants talibés. Donc, ici au Niger, c'est une, comment on l'appelle, c'est une tradition chez nous. Donc, vous allez voir un marabout avec plus de 200 talibés derrière lui. Et ils vont habiter dans une case qui ne dépasse même pas 4 mètres carrés. Donc, ces enfants-là, ils sont exposés à tous les fléaux, y compris le problème du paludisme. Donc, d'autre part aussi, vous allez voir les enfants de la rue et les enfants de la rue. Donc, les enfants de la rue, ce sont les enfants que leur maman abandonne souvent. Donc, dans les poubelles, et ces enfants-là, ils sont aussi exposés, ils sont toujours exposés, en tout cas, comment on l'appelle, au paludisme. Les enfants de la rue, c'est les enfants aussi qui quittent leur cercle familial pour, en tout cas, vivre dans la rue. Donc, ces enfants-là, ils n'ont même pas là où dormir. Vous allez les voir sur le trottoir, au niveau des feux optiques, partout. S'ils trouvent, en tout cas, ils dorment là-bas, sans moustiquaire. Donc, voilà ce que j'aimerais ajouter en détail, quoi. Merci beaucoup.
Perfect.
Hello?
Thank you very much, Sully. Yes, thank you very much for highlighting that particular part. And I'm just going to go back to Susten. Susten, what are you doing with the data you're collecting? How has it informed some of the advocacy efforts in the eradication of malaria? In Malawi, of course.
Thank you very much. This data we collected through Matchbox analysis has opened our eyes to engage also different ministries so that they have to relook at the policies. For example, Ministry of Gender, we have to engage them, and also Ministry of Education regarding the nets in schools. So we are engaging them continuously so that some other policies should be put forward so that deliberately we have to protect our children in schools. Though we have started implementing right now, but the engagement process is continuous. It's heavily recommended that we have to engage these multi-sectoral stakeholders. So it's a process, as you have said. Thank you.
Thank you very much, Susten. It's always, good to hear about what the data is actually being used for. So ladies and gentlemen, we were going through the malaria toolbox, Matchbox tool, and we were trying to see what it does, what it is, who can access it, who's using it, and what are the findings and experiences of the people who actually interacted with the Matchbox itself. And as ENASO, because we're one of the organizations tackling the Anglophone and the Lusophone countries in Africa, where we strongly do advocacy around health. We're also asking, what can ENASO do better? What would you like to see ENASO doing, not only within the fight of malaria, but other healthcare issues that are ongoing? So you can type any sort of recommendation that you have on the chat. I know we were supposed to only have an hour, 30 minutes. I'm going to call out just one last roll call. If there's somebody who has any burning question, any comment, or has interacted with the Malaria Matchbox tool and would want to share something from their own country. Jonathan, yes. Jonathan, you can unmute. Over to you.
Okay, thank you very much, and good afternoon from Ghana. I think it's a great opportunity to listen to this resource sharing on Matchbox. I think Ghana too is being conducted, but it's led by the National Elimination Control Program. Yeah, but as one person said, because it's done at a higher level, sometimes civil society inclusion during the process is very weak. And also, one thing I've realized is that the Matchbox issues when it comes to gender and human rights. Sometimes some of the issues are not so much specific, so that we will know that these are. So when we are doing programming concerning human rights and gender issues, HIV and TB carry the whole thing away, leaving malaria behind. So that has been our problem over the years. So I would like to see that the human rights issues and gender issues need to be well articulated in Matchbox exercises, so that at country level we'll be able to follow those things as civil society and make sure that people who need interventions through human rights and then gender issues, they will also receive their care. Thank you, and
Thank you very much. I appreciate it. Is there anybody else who would like to give in a comment? And I like the fact that you've reiterated that it's being used in the national level. So that's a good thing to know that you've already interacted with it at one particular level. So ladies and gentlemen, we are going to carry on with the Mentimeter, of course. This is just some of the feedback that came in while we were having the discussion. And also, we'd like to hear from you. The Mentimeter is still live, but this is just to show also the answers that came in terms of the questions that we were asking. I'm going to call upon Ida. I know we have 10 minutes so that we wrap up. So Ida, if you can just do a wrap up of the discussion today before we get closing remarks from the Luca from the Global Fund. Ida Rame is now the lead for the Francophone speaking learning hub. Ida, over to you.
Thank you, Lizzie. Can you hear me?
Yes, loud and clear.
Okay, sorry. I will not open my video because the connection is not good. But I will speak in French as we have some interpreters with us. So, thank you. Merci beaucoup à tous pour vos interventions. Je vais faire un bref ramassis de ce que nous avons pu voir aujourd'hui au cours de ce webinaire Malaria Matchbox. On peut retenir en résumé que Malaria Matchbox, c'est un outil. C'est un outil qui permet de faire une étude et qui permet d'identifier les barrières dans la prévention et le traitement du paludisme, notamment les barrières socioculturelles. Et elle permet aussi de contrôler les différentes inégalités. Et elle permet de prioriser notamment le CSJ, les droits humains, les communautés et le genre. C'est un guide qui est assez transversal, qui a une approche transversale. Et nous avons eu l'occasion d'avoir des pays qui ont déjà utilisé cet outil et qui ont partagé leurs expériences. Et notamment, nous avons eu le Kenya, le Bénin, le Congo, le Malawi. Et ce qu'on peut retenir du partage des pays, c'est que dans cet outil, on peut voir les différents groupes qui sont affectés par le paludisme dans les différents pays. Et chaque pays a son contexte. Et l'étude montre que, en général, les personnes les plus affectées sont les populations mal desservies, notamment dans les zones à conflit. Et également, il y a les migrants, les femmes enceintes, les enfants de moins de 5 ans. Et il y a même au niveau du Malawi où ils ont été recommandés, et non, c'est au Bénin où ils ont été recommandés d'ajouter les enfants de 5 à 10 ans dans le traitement chimio-préventif. Donc, nous voyons que c'est un outil vraiment nécessaire pour une avancée dans la lutte contre le paludisme. Et à l'issue de l'enquête, les recommandations diffèrent selon les pays. Il y a des pays où il a été recommandé de faire des formations des acteurs de terrain. Et il y a d'autres pays où il a été recommandé d'améliorer la stratégie de distribution, d'uniformiser les stratégies et les messages de distribution. Il y a d'autres pays où, à l'issue de l'étude, il a été recommandé de renforcer l'engagement des communautés pour l'atténuation des barrières socio-culturelles. Certains aussi ont reçu comme recommandation à l'issue de l'étude d'utiliser les jeunes comme des ambassadeurs. D'autres même ont été recommandés d'ajouter, de joindre les entreprises privées dans la lutte contre le paludisme. Certains, comme le Congo, ont mis en place des focus groups dans le cadre de cette étude et on leur a demandé aussi d'impliquer les pairs éducateurs rattachés à des groupes spécifiques, notamment les pêcheurs, les prisonniers et d'autres populations vulnérables. Donc, en conclusion, que peut-on dire sur le Malaria Matchbox? On peut dire qu'elle permet de lever beaucoup de barrières, d'identifier les barrières et les pesanteurs socioculturels et également, un deuxième point, elle permet d'identifier les populations clés et vulnérables dans la lutte contre le paludisme dans les pays, parce qu'il faut noter que les populations clés et vulnérables diffèrent selon les pays. Et un troisième point, nous avons les données. Et elle permet de la collecte des données qui permet, avec ces données, aux parties prenantes de s'engager avec les différents ministères. Nous avons vu que la lutte contre le palu n'est pas seulement l'affaire du ministère de la Santé, mais il y a d'autres ministères qui doivent être impliqués, tels que le ministère de l'Éducation, le ministère des Affaires sociales, etc., dans certains pays. Et ce qu'on peut retenir également, c'est que le Malaria Matchbox doit être utilisé surtout au niveau des programmes nationaux de lutte contre le paludisme. Parce qu'il faut des gens qui interviennent déjà dans le domaine afin de pouvoir utiliser cet outil. Et aussi, la société civile doit s'engager aux côtés des programmes nationaux dans le cadre de l'utilisation de cet outil. Donc, l'outil permet, l'adaptation de l'outil est disponible et elle permet de changer certaines pratiques dans la lutte contre le paludisme. Voilà un peu, Lizzie, ce que je peux dire sur ce qu'on a vu tout à l'heure en résumé sur l'utilisation de l'outil Malaria Matchbox. Merci.
Nimesahau kama nazo imeanza tangu saa 9, nimekumbuka sasa hivi.
Sorry about that. I know you were just summarizing. Sorry about that. We've muted the other participant.
It's okay, Lizzie.
Okay. Carry on, Ida.
Yes, Lizzie, it's okay.
Perfect. Thank you, Ida. We appreciate it. And of course, it's always a pleasure just having all the partners here. Azia, Naso, and Rami, we're always looking forward to knowing how we can improve our advocacy efforts. So if you have any topic or if there's something you'd like the two platforms to be doing across the African continent, please feel free to chime in, write your text or what you'd like to see us talking about in the next coming discussions. And I've also taken note of the comments that have come in. And I like the fact that Michael Mwanza also said he's interacted with the toolbox and he strongly recommends this in the fight against eradication of malaria. So we have a few minutes and I'm just going to call the last speaker. Sorry, Niluka, you know, we always save the best for the last, but over to you to just give us a closing remark. Yeah, there you are. Give us a closing remark. This was supposed to be an hour and a half. We've overdone it, but this is how interesting it is when it comes to communities talking about, you know, health and the issues that affect them. And it was good just to learn all through. So Niluka, over to you.
Thanks, Lissy, and thank you, everyone. My name is Naluka, and I work with the Community Engagement Strategic Initiative at the Global Fund. A big thank you to colleagues from the national programs who've joined us today. We really appreciate your commitment to the fight against malaria, as well as to make sure that communities are engaged throughout these processes. Big thank you to Yanaso Rame, the Anglophone Africa Learning Hub, and the Francophone Africa Learning Hub, RBM, you know, coming together to organize this webinar and to share these lessons across the African region, but which is also quite important when we look at other regions in the world where malaria is a concern. One of the key takeaways from the webinar today is that there are so many lessons learned and key findings that as communities and civil society, we can definitely use to strengthen our advocacy. As Alistair and the other presenters have emphasized, the Malaria Matchbox is designed for the national programs, but it doesn't limit us, or it's not mutually exclusive from us being involved and engaged with the national programs and using the outcomes for our advocacy to push for more, as we always do as communities within very limited resource settings, to really push for our cause. So thank you everyone for being here and at the Global Fund and at the Community Engagement Strategic Initiative. Together with our learning hubs, we are here to support you and your advocacy and to strengthen your engagement in national processes, including Global Fund processes. So kudos to everyone, and I look forward to working with all of you. Thank you, Lizzie, and thanks, Glory.
Thank you, Niluka. Thank you, teams. Yes, for me, UMYC, Dr. Ismail, Rami, of course, and the two platforms, and ENASO's team. I know they're working very hard behind the scenes. It's 1 minute to the time. Glory, over to you. We've wrapped it up. Thank you very much. I've been your moderator. Looking forward to having more discussions. Glory.
Yeah, thank you so much, Liz. Special thanks to the government colleagues. We really appreciate and looking forward for more interactions and other webinars that we can organize together. For the malaria communities, we would like to let you know that as the Learning Hub, we are supporting, we have the technical support opportunity from the Community Engagement Strategic Initiative. And if you'd like to know more about it, visit our website, as well as you can reach out to us through our email. Liz, you can just write that email that they can reach out, so that we can support you on how to fight against malaria. This is our call. So thank you so much, and let me wish you all a very, very nice rest of the day. Bye.
Thank you. Appreciate it. Bye all.
Thank you. Bye.
Bye-bye.
Bye bye.